All right, thank you very much, Ekene Nduloi, for that background. With us in the studios to discuss the issues around universal health coverage in Nigeria, let's welcome Dr. Yusuf Tanko Sununu, who is chairman of the House of Reps Committee on the Healthcare Services. Honorable Sununu, pleasure to have you this morning.
Thank you, sir.
Okay. Also here with us in the studios is Dr. Ahmed Dunphy, who is director of the Federal Capital Territory Health Insurance Scheme, and also former medical director of the Kubwa General Hospital. Dr. Dunphy, welcome to Good Morning Nigeria.
Yeah, thank you for having me.
Okay.
And from Sokoto Network Center, let's welcome Dr. Chris Osa Isokbon. He's the Director and Senior Technical Assistant to the Honorable Minister of Health. He's also the Secretary, Ministerial Oversight Committee of the Basic Healthcare Provision Fund. It's a pleasure to have you join us this morning.
Very much, my pleasure to Good Morning, viewers.
Via Zoom is Dr. Betta Edu, Commissioner for Health, Cross River State, and Chairman, Forum of Commissioners for Health, Nigeria. It's good morning and welcome to the program.
Good morning. Thanks for having me.
All right. Once again, our pleasure to have all four guests with us on the program this morning. Perhaps we'll begin this conversation with our guest in the Sokoto Network Center. That's Dr. Chris Isokbon, who is a director in the Federal Ministry of Health. Dr. Isokbon, tell us, what are the critical issues in universal health coverage for a country like Nigeria?
Thank you very much. First of all, we need to understand what universal health coverage is. It's actually having essential health available for all people in a country or community. The essential health services that they need are the quality at which it will be made effective, and in such a way that it does not create financial hardship to the persons. So the critical issues will arise from all of this. First of all, what is this essential package of health services? We'll be looking at it from four angles. We're looking at the reproductive, maternal, newborn, and child health component. Actually, the World Health Organization divides it into four: the reproductive, maternal, and newborn health component. There is the non-communicable diseases, infectious diseases, and then you look at the other part of access to health services and capacity. Under this area, therefore, you'll be looking at human resource, a major challenge. Human resource, access to health, availability of health facilities, primary health care facilities. As a matter of fact, the entry point, the gatekeeper for universal health coverage is the primary health care. So there has to be the facility, there has to be the human resource in those facilities. And thirdly, there have to be essential medicines in those facilities that can provide the health care that the people need. And then again, another point is that the funding must be there in such a way that when people access those services, they do not have to go into any financial hardship. If the money is much and it is catastrophic for the people, then they now have to make choices, either to forgo the health service entirely, or they have to sell and take on some other coping measures like selling their property, even sometimes their own assets that is supposed to bring money to them. And that will dip them further into poverty. In Nigeria today, there are about 43 million households, and about 16% of those households actually incur catastrophic expenditures. The Basic Healthcare Provision Fund is one stopgap measure that government has brought in place and is enshrined in the National Health Act to address that, especially for the poor and indigent Nigerians who cannot access the health insurance as it is in the formal sector. You will understand that there are about 17 million people presently accessing the health insurance, or who have access to health insurance. But most of it are largely in the informal sector. So Basic Healthcare Provision Fund will address some of those who are in the informal sector, who are poor, indigent, and do not have access to the health insurance. And then, of course, there are other programs of the National Health Insurance Scheme that are also addressing the informal sector. I would like to mention the group insurance, that is the group and family social health insurance scheme, where philanthropists or individuals can decide to pay the premium for the health insurance of people in a certain community. One thing I need to underscore is that for us to achieve universal health coverage, a health insurance program is key. And the health insurance program is about pooling of resources. So it's not just going to be about a few people paying for it, but it's about a wide pool of resources so that the principle of health insurance is addressed, which is one, those who are not sick can provide for those who are sick, and the rich can also contribute to the health of the poor. And therefore, it ensures equity, it ensures that quality health care is provided for the people. And that is why it is important that all state governments should continue to contribute equity in their state social health insurance scheme. And we should be looking at a situation where we pool all the resources together, because the bigger the pool, the easier it is for us to cover all Nigerians. As of today, like I already mentioned, about 17 million Nigerians have one form of health insurance or the other. But that is just about 8%, 8.1% of the total population. And we'll have to continue to scale this up.
Thank you very much, Dr. Esokunwu, for your initial comments. But I just want you to speak again, or if you like, clarify some of the numbers you gave before my colleague goes to another guest. You said there are some 43 million households in Nigeria. And what percentage of those numbers are in deep financial crisis in accessing healthcare? That's one. And secondly, the number or the percentage of Nigerians that have access to the health insurance. We've been, of course, bounding the figure of 5%, but I heard you say something about 8%. So once again, if there are 43 million households in Nigeria, as you said, what percentage of that is in deep financial crisis in accessing healthcare, and what is the percentage that has access to health insurance?
Okay, I'll go again. When we talk about catastrophic health expenditure, we're talking about health when a household is spending about 40% of their non-food expenditure on health. And the data that are available shows that about 13.4% of households in Nigeria are spending that amount. But 16% of the households in Nigeria are spending above 10% of the available resources that are the total expenditure of the household, above 10% of the total expenditure of the household on health from their own pocket. For the health insurance, the latest figure that we have today is that about 17 million Nigerians are on the health insurance scheme. This includes those in the formal sector, those in the informal sector, those that are covered by the state government. Of course, you know that all the states, as of today, all the states have the social health insurance scheme, and about 26 of these states are actually effective and functioning, have started enrolling people on their social health insurance scheme. I also mentioned the fact that the National Health Insurance Scheme, NHIS, had introduced a scheme which we call the gift ship, which provides that for people philanthropists, organizations can actually decide to pay for the health insurance of a group of people in a community. And actually, maybe I should use this opportunity to call on political leaders and philanthropists to take advantage of that giftship in your community. Instead of people coming to you every time to say, my wife cannot have, I can't give birth, I need money for hospital bill. You could as well just decide, pay 15,000 naira for the year, and it provides insurance coverage for that person. But the key in health insurance is pooling of resources, bringing all the resources available for insurance, in health insurance, together in one pool, such that everybody can have access to it.
Well explained, but Kingsley, in the course of this program, we will get to know whether there is a particular plan or a focus of the Ministry of Health for the achievement of this, universal health coverage in Nigeria, yes. Because that is very critical. Having been able to explain all the dimensions of it, well, is not enough until we have a master plan for it in Nigeria. And that's why I would like to go to the House Chairman on Health Care Services in Nigeria, Dr. Yusuf Tanko Sununu. What is the reading of the universal health coverage in Nigeria by the House Committee on Health Services?
Well, thank you very much once more for inviting me to bury this important coverage. Talking about universal coverage, any time spent to do that is not wasted, because that's the global focus. And as he earlier mentioned, is that all over health is becoming a human rights issue, and that no family should suffer financial insecurity because of the need to secure health. As a gynecologist and obstetrician, I can remember a family that the husband has sold his farm for him to get his child, the wife operated to deliver the baby. Now, it means subsequently he has to go out to hire land for him to continue to farm for his family and to add to the health security of the country. And this is unacceptable. But the reality is that, and we must say the fact, it's no good we continue to sink. You cannot achieve something without foundation. That's the thing. So what we are trying to look now is how do we create a foundation for Nigeria to achieve universal health coverage. Quite all right, there are a lot of improvement, modernization, innovations in National Health Insurance Scheme. But those innovations, the act that established the act as of today did not give them the mandate to achieve universal health coverage. And that's the major weakness, because if you don't have the enabling act or law, it means anytime you try to do something, you are just building. Another regime may come that may not have passion and may just look away from it. And what is that? If you look at the current act of National Health Insurance Scheme, there was nowhere that it was mentioned that basic minimum package is mandatory for every Nigerian. You understand? So because of that, it's concentrated more on the formal sector. So the first focus when we came in is to see how can we amend the National Health Insurance Scheme. And that we have successfully done. And both chambers of National Assembly pass it. And it will only not say, you cannot say, make this thing mandatory without also proposing how fund can be sourced so that it can be achieved. And then in that, this thing, we came up with a lot of innovative funding of healthcare services. We also allowed private individuals, multinational, international, and local organizations to see how they can also key into the system by giving something to the insurance scheme that can be done. Unfortunately, because of a lot of issues, it happens that even after the 30 days, it was not assented to, and it has now been returned back to National Assembly for few modifications that was observed by the executive. And the Senate already has done their own portion, and very soon we'll also consider it in the House of Representatives so that we can concur with them, and then we now have enabling law. Now, if we have that enabling law, it now becomes a human rights issue. People can be asked for violation. You can ask for your right. And the component of that basic package is also defined. And we have also tried as much as possible to increase the scope of funding, as I mentioned earlier, and scope of coverage, you understand, so that everybody will listen. And then we also try to emphasize that, look, key aspect of Nigerian healthcare is for us to refocus our mind, run more of curative rather towards preventive aspect of care services. And that preventive aspect should have started very well and become enshrined in our system in the primary healthcare system. So that, with that, what we are trying to do is to see we restore confidence. Because what we have right now is there is no confidence as far as primary healthcare services delivery is concerned. People will leave the primary healthcare next to their door and go to a teaching hospital to treat simple, I didn't say complicated, simple malarial infection. And the issue is that if you go there, you overload the system, you take much of your time. Instead of being consulted in 30, 40 minutes, you spend 3, 4 hours. Everybody is apprehensive that you are in the teaching hospital. The pressure is just too much. So what is needed now is to see how we can restore that confidence. And we have done that. He has really, the Basic Healthcare Provision Fund is also another gap, as I quite agree. But over the years, since we have started implementing it, the logistic and bottleneck also, he will agree with me, hindered the progress. I, as a person, I took active part as the then Secretary General of Nigerian Medical Association in trying to, and then also as a state chairman of Kebbi State, to see that we impose or we try as much as possible as pressure group to ensure that the government enacted the act. In 2014, it was done, assented, but it took years before it is implemented. And as we are today, and the ministry needs to do the needful, it's a comprehensive document that should be the basic bedrock that will lay foundation for healthcare policy in Nigeria. But one aspect that is only being concentrated to is the portion of basic healthcare provision fund. And it's just about 3 or 4% of the act. There are provision for certificate of standard of our hospital. There are a lot of committees that are non-functional. They were inaugurated, but they have never been allowed to function. And these are the key to also add to achieving universal health coverage. For example, now, each and every hospital that is supposed to be in basic healthcare program must have a certificate of standard. That means they are assessed, accredited, and we are sure that that can provide the basic minimum package. And it should not only be, you should have a general standard, so that if you have that general standard, that your primary health centers, government and public, are standardized, you now have the confidence to go anywhere you want to go. And then the major issue that I quite want to add to him is the human resources for health. And that's also another setback. We are building training and doing everything, the fresher and everything. You have internal migration within the migration. For example, if the pandemic has caused so much damage world over, people are flying out. Internally, people are migrating from the north to west. People are coming closer to their areas because of this thing. And a lot of people also are beginning to see, okay, I can deliver more in other sectors. Doctors move into politics. These are all migration, and they are brain drained. For example, I'm trained as a gynecologist, and I also have a special interest and so speciality as a minimal access surgeon. But because of a lot of factors, I left that discipline, which is also another gap. So it means we have to have a holistic approach.
Migrated to the National Assembly.
Yeah, I migrated to National Assembly. I'm just saying, it's a fact. If we have all these things, what is showing that when you have a whole lot of package, but there are multiple exit points, then you must increase on your entry. So we must increase on our training. We must also increase on our welfare package to return to retain those who are within that cycle, not to move out. Okay. You understand? Even if it should not be in such a way that it will be detrimental. So I quite agree that focus of the world is what universal health coverage, and I also want to agree that we are working to see that we have a foundation for achieving universal health coverage through having appropriate legislation, and that we have done and will continue to do. Thank you.
Thank you very much, Dr. Yusuf Sununu, the migrant from gynecology to the National Assembly. Well, Dr. Isokmuwu already ticked off the critical issues in universal health coverage. And I'm going to the Commissioner for Health in Cross River, that's Dr. Berta Edo, who also chairs the association or forum of health commissioners around the country. There are many issues around this, but let's take the ones we can sufficiently deal with. Now, for the subnational entities, one recurrent issue has to do with primary health care centers. State governments would appear to be more interested in big projects, and then they neglect the small but otherwise more impactful projects such as primary health care centers. Some years ago, the former Professor Isaac Adewale, former Minister of Health, was our guest, and they talked about how they were going to revamp primary health care centers around the country. We had a few commissioners of health join us in that conversation. Probably what they just did was to refurbish one or two locations, repaint them. The minimum standard required for the operation of those PHCs, those standards probably were hardly ever met. And to the extent that PHCs are critical to attaining universal health coverage, why is it that subnational entities remain laggards in this regard?
Okay, thank you very much. I think, again, we need to start the issue from a point which would allow us to appreciate the challenges at the subnational. First, of course, like he said, universal health coverage is health care for all. Good quality care, where they need it, when they need it, and of course, at a way it would not cause financial hardship to those who are taking up this care. More importantly is the fact that universal health coverage involves both promotional care, preventive care, treatment, rehabilitation, and palliative care in most cases. Unfortunately, most of the emphasis of universal health coverage has been placed mostly on treatment, very little on promotion, very little on prevention, which the legislator was trying to highlight. And then, of course, WHO has stated very, very clearly, if we must head towards achieving universal health coverage, three things are very, very key to this whole process. Number one is governance. Governance, political will, political structures, the policy making, the structures from the national to the state to the local government level, and decentralization of power. This is all under governance. The second very important and key reason or key point, which we must focus on as a nation to make progress with universal health coverage, is health financing. And when we discuss health financing, that's when we have all the NHIS, that's the Nigerian Health Insurance Scheme, the contributory schemes that would be able to finance this, taxation, earmarking of funds, several other ways. You've heard recently about sin tax or health tax and all of those things. Those are all health financing that can help us achieve universal health coverage. And then, of course, the final point is service delivery. Are the components which are meant to help us achieve universal health coverage under service delivery, are they there? The human resources, the infrastructure, the drugs, and what have you. Now, when you look at the subnationals, I'll look at them in those three angles: governance, health financing, and of course, the service delivery. Presently in Nigeria, well, I'll be happy to know that we've gotten to 8% because as at the last count, we were somewhere around 5% coverage in the country, but that would be good if we've gotten to 8%. The major issue is the fact that there are some governance issues in the health sector: fragmentation, little political will because of financial constraints at the state level. So you find many states are still grappling with payment of salaries. Many states have low IGR, especially with the COVID coming to make things even worse for states. So they find it difficult to invest in areas that, in quotes and unquote, will not immediately provide revenue to boost the revenue. Remember that healthcare is welfare, social welfare. And so the political will most times are not really that high. But then if you go to almost every state, you have at least one primary health care center in every ward. Are our strategies right and okay? Should we be building more primary health care centers? So sometimes you have constituency projects from the national, they are all going into building more primary health centers. Why don't we put our emphasis on renovation and making those that already exist in each ward functional so that they can offer services? And this is not only the role of the state government. Remember that health is really on the residual list. So the local governments have a role to play, the state governments have a role to play, and the federal government also have a role to play in ensuring that this works. And healthcare is not only, or universal health coverage is not only about primary healthcare centers. There must be that strong referral to secondary facilities. What are the supports to help these secondary facilities function? We can't just leave it at only one level to say, okay, states, you must do this or you must do that. Most states are handicapped, and so everyone needs to come in to support. Secondly, and which is like the main issue, why those primary health centers are not functional, is the manpower. Most times you have beautiful buildings everywhere. Primary health centers are everywhere. In my state, we have several primary health centers. Some wards have 3, some wards have 4. There is no ward in my state that does not have a primary health care center. But what is the level of functionality? Some are 100% functional, some 70%, some 50%. And most of this functionality is tied around the manpower. How many people do we have been produced from our institutions of learning? How many are retained to work in those very hard to reach areas, in rural areas? What are the incentives to keep manpower there? Of course, most doctors will not even work there. Remember, we have probably 1 to 3,000 citizens or 6,000 citizens. This is as opposed to what WHO is saying that should be the manpower ratio to population as it concerns health workers. The health workers are not really there. And when you look at government, are governments ready to employ more health workers? Remember, the salaries of health workers are really very high as compared to other civil servants. So these are the constraints that you find at the state level. While it seems like a lot is not being done, truly almost every state in Nigeria has at least one one primary health center in every ward. The problem is the functionality, and is it able to deliver? How can we make this more functional to deliver? Of course, we have a window of opportunity with the Basic Healthcare Provision Fund, but like the legislator have said, the bottlenecks are plenty. And so most times you don't see the big picture, which is expected to see almost immediately. Some states are still yet to get their funds on one gate or the other. And most times you find out that if these funds were released to facilities and used as required, you should be able to get those facilities to be more functional than they are now. So they can be able to pay for contract staff to work in their facilities, that's health workers that they need. They can be able to provide the drugs that they require there. They can be able to maintain the facility, whether it's light, whether it's water, so that these places are functional and they operate 24 hours. There is a standard for primary health care facilities, which, of course, the Minister for Health has been advocating for. However, we need support from the national, from the state, and even from the local government to ensure that these facilities become functional and can offer services. Cross River State just started offering services to persons who are registered under the state health insurance scheme. We have about 18,000 that have registered and have been paid for. The state employed workers and political appointees, deductions will start in January and they'll have to wait for 3 months, that's 90 days, before they begin to assess care. But then every day as a state, we're trying our best to see how we can improve on health facilities so that the supply side would be as good as what we have said while creating the demand. So basically, if we can work on these 3 angles as a nation, one, the governance.
Dr. Betta Edu, Commissioner for Health, Cross River State. Thank you so much. We'll have to pause you here to bring in our next guest. In the course of the program, we will return to you for more analysis. You have really done some explanations that is quite understandable to us here and, of course, our viewers. So let's bring in Dr. Ahmed Dunphy here. You listened to the 3 guests, who have spoken before now, and the number of critical issues have been raised. And I'd like you to take it from any perspective you would wish to. The last speaker talked about political will. There's the issue of governance. There's the issue of health financing. There's another of creating a foundation for Nigeria to be able to achieve a universal health insurance scheme in the country, all geared towards achieving universal health coverage in Nigeria. You can take it up from any perspective.
Yeah, thank you so much. Achieving universal health coverage in Nigeria is a big challenge. First and foremost, the political will and the leaders, they need to put health as a front burner in their program. Health is something that easily can be pushed to the background because most of the activities in health, they are not things you could probably see physically. And a lot of our leaders, especially at the subnational, when they want to invest in health, some of them might think just building a structure that people will see is what is going to solve the problem. However, we all know that if you build a very beautiful primary care center and the facilities are not there, the human resource for health is not there, it's a waste of fund because such facilities are not going to serve the purpose for which they have been built. So we must encourage our leaders, first and foremost, to allocate more resource to health so that positively most of this impact we expect in health is going to be visibly seen. If you invest some amount of money inadequately, it may amount to a waste at the end of the day. Now, our leaders also have a different priority. Some of them believe, some will even tell you they would rather be doing certain things that the community will see, not knowing that even investment in health means investment in human resource, investment in infrastructure, investment in the social life of an individual. It's a cross-cutting investment. And it does more than just providing the healthcare services. So our leaders should begin to understand this. So there is still a little challenge in that. In other words, more resources has to be made available to healthcare delivery in this country. Now, there's still a little bit of ignorance about healthcare delivery in the system. I was in the National Assembly one day, and a House of Rep member was telling me that he wanted to enroll about 1,000 lives in this country, in his constituency, onto the national health insurance. And there and then, he was receiving calls that members that he was, because they need to bring their passport, and that members are asking, please give us this 15,000. We don't need this. In other words, some people does not even know the importance of this. And you need to educate people to understand the need to be enrolled on health insurance. In fact, the need for them to even take good care of their health care. For example, a community was given health insurance registration. You need to begin to do another sensitization to them for them to go and enjoy these services. These are basic challenges. We are saying that even if the federal government makes available all these resources we need, the information to the people, their knowledge about the importance of this healthcare delivery system should also be enhanced. And so we must look at the level of understanding of healthcare services in the country. Health insurance, for example, a lot of challenges are there. We at the subnational level will tell you. You go and market health insurance to somebody, he does not even know what it is. And he will be asking you, how can I pay so amount of money Are you praying for me to be sick? You know, so this ignorance is still there. So if you look at the level of even our leaders, our leaders either at the government level, you know, their understanding and their commitment to making health insurance work in the country is still very low. So we need to work on that. Now, secondly, there's need to have a strategic mapping. Because look, even when federal government make money available and it is not being judiciously spent, we have not done anything. What do I mean? Everybody knows that you cannot give health when there are no facilities where they will enjoy the services. And so, a very strategic attention must be paid to the healthcare delivery. It has all levels, primary, secondary, tertiary. But the worst of it all is our primary healthcare. The importance of making those functional is that healthcare must be made available close to the people that are going to enjoy it. And if it is not close, some of them can neglect it. There was an eye foundation that came to my hospital when I was MD, and they wanted to help about 200 people for surgery in a village close to Gwagalada. So we planned. They bought diesel, they did all that was necessary. On Saturday morning, when these people are supposed to come in and start enjoying their surgery, we didn't see anybody. So we went back and communicated with the community leader. What's happening? Say, we thought that you people would bring vehicle to come and carry us. If you don't carry us from this place, we cannot come to your place. In other words, if you don't transport them from their local community to the hospital where they will enjoy this service, they are not willing. They are not capable. So these are some of the small challenges that healthcare delivery is still suffering in this country. And so we also...
I'm sorry to interject, Dr. Dunphy. You've raised a number of very pertinent issues relating to health communication, relating to the roles of the subnational entities, relating also more particularly to the political will. I want to throw the issue of political will again, this time relating to the primary healthcare centers, to Dr. Chris Isokmunwu, who is in our Sokoto Network Center. Dr. Chris Isokmunwu, look, earlier you mentioned it. In fact, Dr. Edu also mentioned it, and Dr. Sununu here with us also mentioned it. We talked about personnel, the production of personnel, human capital to man, say, our primary healthcare centers. We don't have enough personnel. But Dr. Sununu talked about migration and so on and so forth. But there is also the paradox, a huge one. Every year you have persons who are graduating from medical schools. You have persons who are graduating from auxiliary medical schools. You have nurses and midwives who are being produced. And yet you have a large number of these persons who are carrying their certificates about looking for employment. They have no jobs. So, and then you ask yourself, what is happening? In fact, for some doctors to even do their housemanship, you have to lobby at some point to get it done. In the meantime, primary health care centers do not have adequate personnel. And in the states, some governors are appointing hundreds of SAs. Sometimes, I don't know whether the figure has hit thousands now, but you are appointing hundreds of SAs, but you don't have funds to appoint healthcare personnel, whether nurses or a doctor, and so on and so forth, to man these health centers. How do we achieve a break-in to change the orientation to say, look, raise the profile of primary healthcare centers through funding, through adequate personnel and supply of medicines, so that we can now begin to expand the percentage of universal health coverage in the country? How do we achieve that, Doctor?
Thank you very much. You have really hit the core of the matter. I mentioned in my introductory statement that the gateway to universal health coverage is the primary health care. But primary health care is the responsibility of the local government councils, the 774 local government councils in the country. However, the federal government, through the National Primary Health Care Development Agency, as an interventionist agency, has been working to develop the primary health care system. I would like to, at this point, talk a little bit about the Basic Healthcare Provision Fund as it affects those primary healthcare facilities. The truth is that there are about 30,000 health facilities in the country, both private and public. And I'm not talking about primary health care. I know people talk about 30,000 primary health care facilities in the country. Not exactly true. There are 30,000, a little over 30,000 health facilities, which are at all levels, primary, tertiary, and secondary, private and public in the country. And almost every ward in this country has a primary health care center. We really do not need, I want to emphasize that word need, not about want, but we really do not need primary health care centers being built anymore. But what requires is upgrading and making functional the ones that are existing. What we need is to have one functional primary health care center in every ward of the country. And once we have a functional one, remember that UHC is about the quality that will make the healthcare service efficient and effective. The Basic Healthcare Provision Fund has, in the last 1 year, provided funding for maintenance of services in primary healthcare centers in 5,829 PHCs. So when people say the BACPF isn't functioning, it's not working, it is because they are not properly informed. But I agree that there are some states that have not taken off. The reason is exactly what Honorable Sununu just said. A health center has to be accredited, given a certificate of standard by the relevant agency to begin to function in the system. State governments were required to upgrade this primary healthcare center to a minimum basic standard that they can now be enrolled on the BACPF to provide quality service for Nigerians. We cannot enroll people to a health center that works once a day, has only one community health worker, and you expect that health center will provide quality service. So you tell the state, upgrade it, provide the minimum number of human resource, provide a minimum infrastructure that will make this health center functional. Then we will enroll people, and they begin to receive service. All the 36 states of the Federation have received money from the Basic Healthcare Provision Fund. Have they used it? No. Many of them have not met that requirement to be given the authority to disburse the funds. BACPF has 4 areas of touch. Strengthen the primary healthcare system. Provide basic minimum package of health services for all Nigerians. We had reviewed it. Some of the bottlenecks that we had, which the Honorable spoke about, was that when it was at inception in 2019, it just provided basic minimum package of health services in about antenatal care for pregnant women, treatment of a few illnesses in children under 5. And we said, no, this is not basic minimum package of health services. And the National Health Act empowers the Honorable Minister to define what the basic minimum package of health services is. So he redefined it. And what he did was to make it more comprehensive. And the health care, basic minimum package of health services that any Nigerian enrolled on the Basic Healthcare Provision Fund gets today is equal to what any Nigerian registered on the NHIS will get. So he gets access to all kinds of treatment, including surgeries in primary and secondary care, at that amount that is paid. As of today, we have enrolled 766,000 Nigerians across 29 states of the Federation who have met the necessary requirements to be enrolled. And of these 766,000 Nigerians, about 200,000 or thereabout have started accessing services across the country. Dr. Edu just told you that they started their own last week. The 18,000 that she mentioned are those that were enrolled on the Basic Healthcare Provision Fund. So the BACPF has started functioning. In fact, as I speak here, we are at the point of disbursing further allocation to all the states of the Federation for 2022 to cater for the people who have already been enrolled, the 766,000, and a lot more, because the target for 2022 is to have a total of 1.3 million of those people enrolled and receiving services. So I've talked about the NHIS, I've talked about the primary health care. The third part is the emergency medical treatment, which will take off next year. What that means is that every Nigerian will have guaranteed treatment, emergency medical treatment. I need to use the word guaranteed. What it means is, if there is an emergency, you call an ambulance, the ambulance takes you to an urgent care center. You are given treatment for 48 hours at least, without anybody asking you for money for payment at that point of care. At the end of that 48 hours, then the funding now, where you not determine, or when the person is out of the emergency, it's then you now determine how do you pay. If the person is on NHIS has covered it, or health insurance, the person has health insurance, that has covered it. If the person does not have health insurance and is able to pay, the person pays. Any Nigerian that has access to that emergency medical treatment and is unable to pay, the Basic Health Care Provision Fund, through the emergency medical treatment, takes care of that aspect of the treatment. Universal health coverage, UHC, is not just about health insurance. It's about making the health facilities available to the people and accessible. So the Basic Healthcare Provision Fund is funding one primary health care center in every ward in the country. And like I said today, one health center in 5,829 wards in the country is receiving funding directly from the Basic Healthcare Provision Fund. In addition to that, part of the fund will be used for human resource. About 2,500 midwives have been engaged on the Basic Healthcare Provision Fund to provide midwifery services in some of those primary healthcare facilities. And many states are getting authorization to engage more midwives and chiefs and even CHUs. But the law also emphasized that states should provide 25% of whatever amount of money that is sent to them on the Basic Healthcare Provision Fund. Not one state has made that 25% available in their own state. And the 25% is to be used for the same purpose in the state. So if we send you ₦1 million, you should bring 250,000 naira as part of that 1 million. So your state has 1.25 million to be used to provide health insurance for your people, and at the same time provide for maintenance of primary healthcare facilities in your state. But not a single state has done that for now. And we continue to advocate for states to support that, that initiative, which is provided for in the law. If we were to go by the law, no state will be receiving funding, because you are supposed to provide that 25% before more funding will be sent to you. But in order to make sure that this system does not collapse, we have made some of those innovations without breaking the law to ensure that states get funding to continue to manage their health system. The fourth part is the health security. So in the Basic Healthcare Provision Fund, there is funding provided for health security. There is funding provided for health security.
We have actually taken down, some of the very pertinent points that you have raised, and some of the issues that have to do with the states not complying with some of the laid down plans that the Federal Ministry of Health has to ensure that the states are covered, health-wise. We'd like to bring in Dr. Ahmed Dunphy here. Sorry, Dr. Tankus Chinunu once more here. We may wish to respond to some of the issues he raised.
Yes, I'd like to respond to some of the issues he raised, most especially the political will, which definitely is key. And we can look at it at national and subnational level. If we start at national, the political will to replace existing staffs, either by retirement, moving out, or what else, is really a serious matter. We are in a situation whereby a vacancy of health personnel to be replaced will take at least 12 to 18 months. And this we have, at the committee, it was made clear by the committee of CMDs. First, it may take you 4 months in the Federal Ministry of Health. To get to the head office of head of service for another 3 to 4 months. It will get to the budget office for another 3 to 4 months. And it will get to federal character for another 3 to 4 months. And that's why we see there was a lot of expansion as far as infrastructure is concerned. But in terms of service delivery, the migration has caused a lot of damage. And as you rightly mentioned, there are people there in the street with their certificate. Some of them are fellows consultants, and some of them are the best brain in the year they've graduated. But because of bottleneck of replacement in the civil service,
how do you break that bottleneck? How do you clear it?
We cleared. We have already, as last resolution we have made, we have asked the executive, the committee of CMD, Federal Ministry of Health, head of service, to go and see how those bottlenecks can be distant. What we have demanded is the money is already available because those that existed, they are within the civil service. Give an express approval and direct approval to head of hospitals because they are representing the government there. And limit the distance. Just notify you that so have left the service. And we are replacing them with so of the same level and grade. And if that is done, you go and verify a due process followed, rather than allowing a ward that have been functional for years. They have 20 nurses to now be manned by 3 or 4 nurses. It's really unacceptable. They are overstretched. This syndrome, when you are overused, you see they lost confidence in what they are doing. Just some few days, I was at Nursing Council for an oversight. I was shocked when I learned that 17,000 nurses left the country in 10 months. That's average of 1,700 per month. That is significant. We've seen. Everybody knew when a multinational came into Nigeria to recruit and take out our foreign brain. Then if you go to the national, subnational level, definitely whether we agree, we must have that political will to free the local government as tier of government. As a chairman of local government, if you cannot recruit, you cannot provide funds for the hospital, you cannot provide essential drug in your hospital because the fund is not available to you. Definitely, you know we cannot go anywhere. This is key.
Yeah, Dr. Sununu,
yes.
Thank you very much. And Kyria, you know, the emasculation of the subnational governments, particularly the local government, is one issue that it has engaged our attention on Good Morning Nigeria. We're taking a short break now. When we return, we'll continue with the conversation.
That is the black swan of the century, has actually hit the whole world very hard, even the strongest of economies, and Nigeria was not spared. But due to the proactive stance and steps that the president has taken, we've been able to come out quickly. The president has consistently said we must invest in infrastructure. Even as we're investing in human capital, that we must invest in infrastructure. Because at the end of the day, that is what will bring about a sustainable economic growth. So the president has given us our directive. He has said you must make sure you pay salaries and pay pensions, but you also make sure that the critical projects of roads, railway, airports, bridges, major infrastructure that are meant to drive the growth of the economy, that we consistently invest in them, even if we have to continue to borrow to do so.
This message is from the Federal Ministry of Information.
Since coming into office in 2015, the Buhari administration has recorded unprecedented achievements in all sectors, especially in the provision of infrastructure, which is the key to economic growth. Never in the history of this country has any administration done so much with so little. Recall that when this administration came into office, the price of crude oil, which provides for 80% of Nigeria's budgetary revenues and 95% of foreign exchange, dropped drastically thus reducing the amount of resources available to the federal government. In spite of this, the administration has continued apace with massive infrastructure developments.
This message is from the Federal Ministry of Information and Culture.
Norwich City are desperate for another 3 points in their battle for survival in the Premier League. Can they cause an upset against the Hammers? This Saturday, it's West Ham United versus Norwich City on the Premier League Live, showing on the network service of the NTA from 3:30 p.m. The Premier League Live is brought to you by Baba Ijebu and powered by Integral.
All right, thank you for staying with us on the program up to this moment. Let's return once more to Dr. Betta Edu, Commissioner for Health, Cross River State. Madam, we have raised a number of points here that tend to show that the subnationals are not playing their roles in the not just in the health sector but other sectors as well. Because some governors of some states, they prioritize, where they put their money. And when it comes to the issue of universal health coverage in Nigeria, the states are very, very critical because, of course, the majority of Nigerians reside in different states. Now, you are a Commissioner for Health in Cross River State. Let us know what you think the governors of subnationals should do to perhaps reprioritize the health sector, to see how they can also key into some of the policies of the federal government on health matters.
Okay, thank you. Basically, a lot can still be done at state levels to improve healthcare, and many governors are doing their little best amidst very tight resources to improve healthcare. However, more can still. My governor, of course, was the one who sent up Professor Benayadi. He was the one who started the state primary healthcare development agency. I used to be the pioneer director general. He was the same person who brought up the policy, sent it through law to start the state health insurance scheme. All of this never existed before him. So first, the governance again, and that political will, commitment to seeing those things work is important. And then, of course, the financing. Even though the states are having very lean budgets, some states or most states are having very lean budgets and are struggling with even paying salaries of workers, of course, they should be that priority given to the health sector. I think another thing which we need to learn to do really quickly is how to frame our language in the health sector. We need to frame our language to appeal to the political class. That way they can understand what it means. If you say manpower lost because people did not receive service, productivity lost, IGR lost because health services were not given, it will help people do more. In my state, a lot has been done around infrastructure, but especially at primary healthcare level. In fact, most of the emphasis are on primary healthcare level. But that being said, I would want to mention two things really quickly. Number one, the issue around contributing 25% to the basic healthcare provision fund. If we can recall very clearly, a letter was written to the National Assembly asking for that exemption at the onset of COVID. And that was done in good spirit to allow states to refocus their funding into COVID response, which took up a lot of funds from the health sector. Now that we're beginning to get our hands around COVID, it's time for states to begin to reconsider this and reinvest in other things that will drive us towards universal health coverage. But more importantly, we've talked about the manpower. The truth of the matter is that we cannot do things the same way and expect a different result. NHS in the UK, I think it's the 5th or 7th highest employer of labor in the entire world. We can create a different vehicle. We can create an intervention vehicle that is contributory by both federal, state, and the local government who are even directly in charge of these primary healthcare centers. We can create a vehicle. whether it's under the NHIS in collaboration with SHIS, such that they are doctors, nurses, lab scientists, pharmacists that are actually employed to work in all of these places, including rural areas, but they are not under federal government employment or state government employment or local government employment. Rather, they are under NHIS employment. This is what happens every day. When you hear doctors leaving Nigeria to go and work in the UK, almost 90% of them are going to go and work as under agency in NHS, and they are being paid. And so they don't bother whether they stay, there's residency and the rest of it. I think we just need to be a little more innovative as it concerns human resources. That way we'll be able to fix the issues. Like you said, there are many doctors walking around without a job. There are many nurses, midwives walking around the country looking for jobs. Gather all of these people, put them under an NHIS program and deploy them both as states, local government and national level, and then of course get the contributory payments from all of this entity. Beyond this, I just believe strongly that as we continue to advocate to governors through the Nigerian Governors Forum, as we continue to use different means to advocate to governors, there will be more emphasis in dedicating or earmarking monies that should go to health specifically. And of course, we must provide that enabling environment to support them.
All right. Thank you very much, Dr. Betta Edu, for the innovative points you have raised, of course, along with the other guests on the conversation this morning. In particular, you talked about the need for stakeholders in the health care sector to frame their language and communication appropriately to the political class so that the political class will see the ultimate benefit in proper healthcare funding, in getting to activate our universal healthcare coverage. But then the other point about employment, which is significant, you say we have to tweak it a bit. I think it will require a sea change in terms of who the employers would be. You say that now it should be NHIS that should, NHIS plus SHIS that should now be the employers. I think that that will be also a revolutionary point. I recognize that, you know, Kieran, my colleague here, that there are usually, if you like, legal landmines with regard to employment, whose employment has a statutory flavor, and so on and so forth. Who is your employer? Is it a state government? Is it a federal government? Is it a local government? And of course, the pension issues have also been cleared up now since it is already contributory. But I think it's significant if we have to borrow from other jurisdictions, such as the NHS in the UK that you talked about. Thank you very much for those points. Now, I wanted to ask Dr. Ahmed Dunphy the issue around health communication, but I think we again pressed for time. It's been, you raised it in the first instance that beneficiaries of healthcare products or healthcare services don't get the appropriate communication. Those who are also providing don't get appropriate health communication. And then the political actors don't also get it. So I believe that that point has been trashed. There's a critical segment to the issues in the universal healthcare coverage. We've talked about PHC and so on and so forth. And those issues around which Dr. Isokmu earlier talked about, non-communicable diseases and infectious diseases. Prevention of those diseases. This year, we have seen thousands of Nigerians die of cholera, more numbers than have died from coronavirus. What are we not getting right in dealing with non-communicable and then infectious diseases in our environment as a way of also elaborating on universal healthcare coverage?
Yeah, thank you very much. The non-communicable diseases and infectious diseases, they are in effect a very major part of the healthcare burden in any society. You have seen what COVID has done to us. That's an example. Basically, in my mind, I think the first thing is to provide for this care, which I can tell you the Basic Healthcare Provision Fund adequately provided for that. In fact, the NCDC is also a major beneficiary for the Basic Healthcare Provision Fund. So that is one. Then two, largely most of these communicable diseases and infectious diseases are more of preventable things. And there's need for a lot of education from the community level to all strata of life, to people to understand. For example, maybe a non-communicable disease that is based on lifestyle, or eating pattern or whatever. It has to be looked at in that respect. And the effort to reach the masses in that angle must be strengthened. Infectious diseases, believe me, some people went to the minister and they were complaining about cholera outbreaks in all of the areas. And they called some of us. And it was mentioned that 90% of the causes of cholera, it has to be due to environmental. Some of them don't have water, no borehole, So that is basically the primary cause of some of those diseases. So if the environment is not being taken care of, and if education, correct education, is not given to the masses, you see that even if you bring all the drugs that will treat that condition, you still not achieve it. So we must, enforce the pattern of sensitization on the disease burden and the causes of the disease and the treatment. And I'm sure to a very large extent that is going to help.
Dr. Sonono. Killer?
Well, thank you very much.
On the same issue of dealing with non-communicable and infectious diseases, how do we reduce the burden in our society?
Well, I think first of all we have to prioritize, because we're in an era of emerging and emerging diseases. There are diseases that have global politics attached to it. There may be less impact in your own society, but because it has a lot of global implication, the tendency is that everybody will gravitate towards, attention will be paid there, and we neglected the common cause. You have just mentioned corona virus, and everybody is aware that more people died of corona than due to cholera than coronavirus. But if you look at it globally, it has become a policy that each and every country must improve and promote its safety in terms of prevention, treatment, and care, vis-a-vis immunization and rest, for you to have global access. So because of that, definitely much attention will be paid to that. But if you come also down locally, you find that there are a lot of issues that require a holistic approach. If you look at cholera, as you mentioned, it's mostly environmental. So these are diseases that require multi-ministerial collaborations. You cannot eradicate it only through Ministry of Health. Ministry of Water Resources is there, Ministry of Agriculture is there, Work and Housing is there, Environment is there. So you have to have this thing. Now, even when I was at least at a younger age, but I think at that time, you all know what I'm going to refer it. In each and every village, we have community health officers. In Hausa, we call them Dubagari. And I knew, as at that time when I was in primary school, and even at my early part of secondary school, once they say Dubagari is coming into your house, you see our elders rushing here and there to cover up everything. These are the sanitary inspectors. Mm-hmm. But gradually, I don't know, with every time, they tend out to be this thing. And that's why, and what happened is because we have changed our focus from preventive more to curative. And that has also cost us expensive. What we are now spending to cure and treat infectious diseases, these are the money that are now used by developed countries to build infrastructure.
All right, sir.
So I think we have to prioritize and have a holistic approach.
All right. Let's return to Dr. Chris Isobon. You have really done some explanations, that are very critical to this conversation this morning, and they're all quite understandable. But what I want to ask you now that we are winding down on this program is, from what you have explained, are we creating a foundation that will gravitate into Nigeria achieving universal health coverage by 2030?
Thank you very much. I can tell you with all sense of responsibility and honor that the implementation of the Basic Healthcare Provision Fund sets the stage and good foundation for achieving universal health coverage for Nigeria. What we need to do, and which is what we are doing at the ministry at this time, is to demonstrate transparency, demonstrate that it works, and then attract the necessary resources into the basket. As we speak, we are getting such resources in the basket. What we need to continue to pray for is for federal government's resources to increase so that the 1% of the Consolidated Revenue Fund also continues to increase. While we seek other innovative methods of funding, I would like to appeal to the subnational governments to please support the fund by meeting their own obligations, as well as working with our agencies, implementing agencies, to ensure that these facilities are ready to provide the needed service for all Nigerians. Finally, I would like to call on Nigerians who are enrolled in the Basic Healthcare Provision Fund to please avail themselves of the services that are available. If they don't, then the funding from government will be a waste. And I know that once the more Nigerians we take out of poverty through this initiative, the more productivity the country gets, and that improves the GDP of our nation.
Well, Dr. Isokun would like to thank you very much. We are again pressed for time now, so we can't reopen this aspect. There was a suggestion by Dr. Betta Edo in terms of the new employment approach for medical personnel, whether doctors or nurses, rather than having them as statutory employees, either of the federal government or the state government, let the NHIS or the SHIS run them. You run them as a business, and then you are the employers of these persons. Contract of employment is founded in law in the first instance anyway, and if you breach it, there are remedies for the party that has suffered a breach. It's a topic I believe that Kirian will have some interest in going forward. Let's see what happens in other jurisdictions. We've had Nigerian practitioners in the Americas, in the US and Canada, speak to us from time to time. We can also find out from them how that works and whether there are obstacles towards the full implementation of that for our country. Dr. Yusuf Tanko Sununu, Chairman, House Committee on Healthcare Services, we appreciate your being with us on Good Morning Nigeria today.
Thank you, but I just want to say basic healthcare provision is no foundation, but it's another source of funding for the Universal Health Corporation.
Thank you. Now, Dr. Ahmed Dunphy, Director of FCT Health Insurance Scheme and former MD, Kubwa General Hospital, we appreciate your being around this morning.
Thank you very much.
Dr. Chris Isokun, who is a Director and Senior Technical Assistant to the Honorable Minister of Health, and also Secretary of the Ministerial Oversight Committee of the Basic Healthcare Provision Fund. We appreciate your contribution to the discussion this morning. And last but not the least, Dr. Betta Edo, Honorable Commissioner for Health in Cross River and Chairperson of the Forum of Health Commissioners in the country. Deep thanks for your insights. All right, so that's it for us on Good Morning Nigeria for our conversation segment. But just before we go, let's go back to our sports desk.